Gentlemen, you're live and recording.
Thank you, Valerie. Alrighty, good morning and welcome. It looks like the webinar is up and broadcasting and you're streaming in. My name is Dr. Tim Hess and I'm here with our Executive Director from the Washington Academy of General Dentistry, Valerie Bartoli, and our panelist, Dr. Gary Hayamoto. We're bringing to you today the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. We really appreciate everybody that's joined us and continues to join us on these webinars. These webinars are being brought to you absolutely free from the Washington Academy of General Dentistry and our sponsors. And right now, you're seeing a list of speakers that spoke yesterday. And just we're getting really some incredible webinars out of our speakers and presenters. If you miss one, if you want to share one, please go to YouTube, and it's Washington Academy of General Dentistry. Just go to our page there at YouTube. Remember to like and subscribe and hit the bell so you get notifications when new webinars are up. Like to welcome Dr. Michael Fling today that's going to be presenting. I know that's why you're here. And just a reminder that after Dr. Fling at noon today, Deborah Engelhardt-Nash will be presenting. And then in the afternoon, we have Michael Giardino from the University of Washington Grad Perio program that's going to be updating us on the Perio classification system. On Monday, we've got Dr. Ross Nash, who's presenting on indirect aesthetic dentistry. So, like to thank our co-sponsors. The University of Washington School of Dentistry CE is handling your CE credits. You will receive CE credits in the mail within the next few days. So be looking for an email from the University of Washington School of Dentistry Continuing Education. Should come as a PDF. Save that PDF for your records. AGD members, we're pleased that we can submit your CE credits directly to the Academy of General Dentistry, and those CE credits should show up on your transcripts within 2 to 4 weeks. Other co-sponsors include the Canadian Academy of Restorative Dentistry and Prosthodontics, Comet USA, Patterson USA, Seattle King County Dental Society, Snohomish County Dental Society, and Pierce County Dental Society. We've got something special that's continuing is our implant study club with Dr. Yassine. On the 29th, Dr. Catafucci will be joining him. So that will be one for those of you that have been following Dr. Yassine. Just added Dr. Ann, Thursday, April 30th. This is probably the best intraoral scanning lecture I've ever seen. Don't forget April 30th, we're gonna bring Omni back, and they have a number of guests that are going to be continuing the Leadership Through Crisis webinar series. Thursday, May 7th is Canadian Academy of Restorative Dentistry and Prosthodontics Card P Day. We've got our speakers lined up. Dr. Kim Parlett will be presenting at noon. We've got Mark Douglas will be presenting in the morning, and then Ian Tester will be presenting in the afternoon. So mark your calendar. We don't have the registration up for those yet. As you notice, some of the flyers have QR codes. You can use those QR codes to register for upcoming webinars. As we get the webinars on our website, the washingtonagd.org, then you'll be able to get registered. So sorry those aren't up right yet, but we'll get them up here within the next day or so, and you'll be able to get registered. So if there's not a QR code, just check back at that website. And as I say, those should be up in the next day or so. If you're not an AGD member, that's no big deal. You'll still get CE. Please feel free to share the links to these webinars with your staff members. with your colleagues. Everybody's welcome to attend. Everybody will get CE. So, you know, there's no problem there. Encourage you to become an AGD member. For you young dentists out there, to be a member of the AGD in your first year is only $78. So, you know, that's a good value. The membership is tremendous with all the different benefits that are available there. Here's the QR code again to get to the WAGD. So CE, so we don't get this question a whole bunch of times in today's webinar, that CE will be emailed to you with the email address you registered at within the next couple of days. I know Dr. Fling is ready to go here. So what we're going to do is just, let's see. Oh, we've still got people ticking in. We have over 900 people registered for this webinar today. So we'll just give a couple of minutes. I know some of you are new to the Zoom format and just play around with the application a little bit. If you're not seeing things on your side correctly, it's probably a setting on your side. It's not something that we can control here. So you can move from speaker view to gallery view, etc. Today, we will be fielding questions for Dr. Fling. What we'll do is have you place your questions in the Q&A section, okay? Not in the chat feature of the application, but in Q&A. Now, if you go into Q&A and you see there's a question there that you like, you can upvote that by checking on the thumbs up. So please do that. And that way, I'm sure we're going to have quite a few questions at the end. We can deal with the questions that most people want to hear the answer to. So with that, I'm going to say again, thank you to all our sponsors, the Washington Academy of General Dentistry, the University of Washington School of Dentistry CE Department, Pierce County Dental Society, Snohomish County Dental Society, Seattle King County Dental Society, the Canadian Academy of Restorative Dentistry and Prosthodontics, and our friends at Comet USA and Patterson Dental. Well, it's time to introduce Dr. Fling, and I'm going to read his bio here. Dr. Fling began his career in dentistry in 1976 as a laboratory technician. Graduating from Oklahoma University College of Dentistry in 1984, he maintains a private practice with an emphasis on restorative dentistry. He has served as course director and clinical assistant professor in the Department of Fixed Prosthodontics and currently serves as director of advanced restorative dentistry at the OU College of Dentists. He is the founder and president of Fling Seminars, providing advanced dental education to dentists, dental teams, and technicians throughout the world. He also serves as an associate faculty and course coordinator at the L.D. Pankey Institute. He has completed the process to be awarded the title of Pankey Scholar. As a member of the American Academy of Restorative Dentistry and the American College of Dentists, he has lectured internationally to dental and laboratory associations and to various study groups on fundamental principles of restorative dentistry and achieving technical excellence. He has been named as one of the top 100 clinicians in dental education by Dentistry Today every year since 2005. He has published numerous articles and is the author of 32 Laps, Tipping Points That Motivate Change and Identify Meaning in Your Business and in Your Life. It gives me great pleasure to welcome our friend, Dr. Michael Fling. For those of you that haven't met Dr. Fling today, you're going to see a dynamic speaker. And I just want to remind you that he will be one of our master track speakers for our 2020-2021 series. So please, if your interest is piqued, register for that master track series. Dr. Fling, it is a pleasure to welcome you. And, you know, we're going to, and please, people, keep the comments nice. You know, Oklahoma stole our supersonics. So, and Dr. Fling's a big fan. Dr. Fling.
It's true, and if I told you the owner of the team was a patient, that probably wouldn't sit well either, would it? Oh, well. So, thanks for having me, Tim. It's always a pleasure. I would tell you this is the first time I've ever done a presentation from my bed. I'm here in Oklahoma right now. I don't know if you can see out here. It's raining. This is my bedroom, and it's a rainy day here. I've spent the last month in my garage working on my race car. I got to tell you, that thing has been rewired, and anything that can be done to it and updated on it, I have done it. We actually start back to work on May the 1st. So we're anxious to get back with it. So it's been an interesting time. Why don't I begin? I'll go ahead and share my screen here. And there we go. And it's what we're going to visit about today is some concepts in regards to the anterior segment. And I entitled it the anterior segment as we're dealing with both the reality of it and the perception of it. On the lower right, you'll see that is my cell phone number. Feel free to reach out to me at any time. And then that's my personal email address, mcfling@aol.com. Feel free to email me. If you do, put something in the comments so that I'll know that it's not spam or something crazy like that. But feel free to touch base with me at any time. You know, it's what I want to really express is the concept that as we deal with the anterior segment, there's so many things that we have to consider in regards to aesthetics, in regards to how do we make these people better. I actually just had published a technique where we actually do a diagnostic wax up, and I make these shells out of different materials. I will use Luxacrown, I will use flowable composite, I'll use different bisacryls, and we make these shells, and then I can reline these in place to really create some nice provisionals. So, you know, for me, I want to get a provisional that is really going to mimic what I want the final restorations to look like. And obviously, in this case, we're going to have him wear those for a period of time so we can start to get his tissues healthy before we even take final impressions and before we go to final crowns. But at the end of the day, we've got to start to ask questions like, what is this supposed to be shaped like? And what are some things that we can do to ensure that this can look as good as it can possibly look? Because finally we get to a point where things are healed enough that we can then progress and go ahead and go on to permanent restorations. So I'm going to give you some insights into some things that I do every day in my practice. They're just some little nuances, some different ways that we can cheat to make life a little bit easier, some things we can do to help our outcomes come out just a little bit better. Now, as he shared with you, I have a heavy emphasis in my practice in restorative dentistry, and I do a lot of my own lab work. And I realize that for most restorative dentists, that's not very practical. But I do my own diagnostic wax ups. I'm not saying you need to know how to do it, but it's what I am telling you is if you can understand some of the very, very minor things in the anterior segment, it will help you in terms of your provisionalization. It'll help you in terms of maybe if you're doing direct composite bonding. It's just that little bit that just really takes you to the next level. The other thing I want you to understand is what I have there on the second from the last line, and it's right there. Some of my dentistry sucks. And it just does. It's the truth. I would tell you that I look at dentistry I did, you know, maybe even a year ago, and I scratch my head and I go, my goodness, what was I thinking? So I think the idea is that we just keep trying to get better and do everything the best way we can. One of the guys that has just really influenced me so much in my practice has been Bill Robbins. And as many of you know, Dr. Robbins came up with the concept of global diagnosis. And it's what it boils down to is we start by taking a measurement from glabella to the base of the nose to the bottom of the chin. And in an ideal scenario, that ratio should be about 1:1. So as we look at that, we then understand that we can take this evaluation, and we always do that when the patient is in repose. And when we do that, we can break these segments down. So you can go to Harbor Freight, and for 19 bucks, you can buy this little measuring device, a digital measuring device. And you'll notice in this scenario, he's about 1-to-1. So that's typically about what we would like to have. Now, after we've made these measurements, you can get the lower half and you can break it down. And as we break the lower half down from the base of the nose to the bottom of the chin, we've got one area from the base of the nose to the bottom of the upper lip. That measurement should be around 20 to 22 millimeters. And for guys, 22 to 24 millimeters. Now, here are some things that we know. As life goes on, we have continued growth of the face. It grows out and down. So it was very interesting. Last night, I was watching a movie, a show actually, and it had pictures of him today, but it looked back on his life when he was 25 years ago. And 25 years ago, he had a very gummy smile. Yet today, he doesn't. Well, the reason is that the face grows out and down, and we show less and less upper front tooth. So that's a reality of what's there. One of the things that we can do perceptively to make somebody look younger is we can give them longer front teeth. So if I've got somebody with short, worn teeth and they don't show much tooth, I could say, Miss Smith, one of the things we can do to perceptively make you appear younger is we can show more of the upper incisal edge. So we know that as we age, the face grows out and down, and we show less and less of the upper front tooth. So we can simply make those measurements, and so you'll notice on the right side, once again, we just don't show as much tooth. Now, in regards to the lip, here's what we know. That when you go from a position of repose to a full smile, on average, the lip will hop up somewhere between 6 to 8 millimeters. So keeping that in mind, in this scenario, we understand that we have got a lip length. We understand that we've got a distance from the glabella to the base of the nose to the chin. We understand where we would like the incisal edges to be. I'm setting you up because I want us to understand as we deal with the upper anterior teeth, we want to fit those in the smile in a particular place. So I would like the incisal edge to follow the drape of the lower lip. And I would tell you that one of the biggest errors I see in evaluation of the upper incisal plane is that we evaluate this while the patient is sitting in the dental chair. And is what I want to encourage you to do is when you're evaluating an incisal plane, I want to encourage you to do that while the patient is standing up. If the patient's in the dental chair, you're looking down at them. And as you look down at them, you can get, it can appear that you don't have a flat incisal plane, but then when that person stands up and they're 6'2", who knows, that incisal plane might actually be negative. So it's critical to look at this while the patient is standing. We know that ladies tend to show a little bit more incisal edge than guys. That's just the way it is. And we also know that we would like the free gingival margins to be on about the same line. The lateral incisors actually are down just a little bit in this free gingival margin area. And we know that we would like the incisal edges to follow the contour of the drape of the lower lip, and that the incisal edges of the lateral incisor are slightly up. But my goodness, there's so many variations to all of it. So we've got to start to understand, what can we do to make this more ideal? Now, I mentioned to you that I do my own diagnostic wax-ups. And one of the things that we're going to end up doing here in just a little bit is I'm going to ask you to do a drawing. Now, one of the things I think is critical to understand is that we always start, when I do a diagnostic wax-up, I evaluate the width of the maxillary central incisor, and the lateral should be about 75% of that width. So we're going to look more at these ratios in just a little bit, but that gives me an idea of how do I want things to be. So the reason I mention that about Dr. Robbins is that he was so instrumental, I think, in affecting how I diagnose things in my practice. I then took that a step forward, and I've developed what I call the global restorative sequence. And in that restorative sequence, the first thing we start with is global diagnosis. So we start with that, and once I've created that global diagnosis, I now have to ask the question diagnostically, how do I put all this together? In other words, in the lab, what do I do to develop the case in the lab or on paper, however you might do it, before I go to the clinic and actually apply that in the mouth? So I've got a diagnostic footprint that I want to develop, and then I want to have a sequence in the treatment room that we do. Now, we're not going to go through all this today because that's not the point of, that's not our focus today, but these are the 7 steps of the diagnostic footprint. We start with global diagnosis, and we're going to affect treatment as needed for that. We've got to manage the airways, and we're going to have models that are mounted to centric relation. So that's the second step. The third step, you'll notice, we begin by getting the upper anterior incisal edge in the correct place for aesthetics. So that's what we're going to concentrate on today, is what can I do? What is the reality of that scenario? What can I do perceptibly to maybe cheat and help us with that? So that third step was the upper anterior incisal edges for aesthetics. Remember what I just said. When I do a diagnostic wax up, the first thing I do is I measure the width of the maxillary central incisor. Once I have that width here, or in this case right here, I know that the length of that tooth should be about 25% longer. So now I have a choice to make. Do I bring the incisal edge down 25% longer? Do I raise the free gingival margin up 25% longer? Or do I have a combination of those things? And that's what we have to figure out based upon the goodies that we gather. So I start my wax up by establishing the length based upon the width of the maxillary central incisor. Then, after I get the upper anteriors where I think I want them to go, it's a matter of getting the lower anteriors. After I've got the lower anteriors, that anterior segment's correct, then I simply level the lower occlusal plane from front to back and side to side, and then it's a simple matter of then having the upper posterior correlate to the lower posterior. So that's just an overview of that sequence, and that's the process that I use in the lab to do my diagnostic wax up. So I know the deal. I get with a lot of dentists and I say, okay, we're going to do a diagnostic wax up. And this is the response I get right here. It's like, there's just no way I'm going to do that. I get it. Well, here's what I would tell you is that when I do a waxing course, which I do a couple times a year, I just think it's one of the most valuable things you can possibly do as a restorative dentist. And here's what I teach when I teach my waxing course. You need to learn to wax like you draw. In other words, you just don't go and put a bunch of wax on. It's what you're going to do is very specifically place wax just like you were drawing the teeth. And that's why I think it's so important to learn how to draw these, because if you will do that, I promise you, if you can get to a point that you can draw these teeth in your sleep, your provisionals, your wax ups, the contours of your final restorations, I promise all of that is going to get better. So in my practice, we do 2 sets of models when I'm doing an evaluation and a diagnostic workup. One set we mount and we leave untouched. That's our before set. And then the other set we complete the wax up on. And I can literally put those in my patient's lap and they can see the before and the after, and they can get a feel for this is what it might look like as we start to do our treatment. So it's a great visual cue for the patients and for me to see what's going on. Now, I want to give you some great ways to cheat with diagnostic wax-ups. Lab technicians won't tell you this because we want to keep it our secret, but there are wonderful ways to cheat in waxing. If you don't have a NA rapid waxer, go buy one. You can get them online. You can get them through Patterson. That's where I got mine. I think they're like 90 bucks. And as what this is, it's just a silicone mold. And as what I do is I get Whip Mix white presentation wax. And you can get it in stick form. And very quickly you can fill this mold up and you can create tooth shapes. And so here you'll see a scenario where on the back of the teeth back here, I have waxed these back teeth using these tooth shapes. So I don't have to spend tons of time waxing up a back tooth. Instead, I get the plaster completely out of the way, and I can very quickly add a tooth and create the shape that I want. And so we inventory these teeth. We have created just a herd of these, and they're labeled lower right, first molar, whatever it might be, and you can just hop in there and grab it, and off you go. So we're not having to search and find these. We've already got them done. So here's another quick tip I want to give you. Go to smilelineusa.com. There's your phone number. And they have silicone molds for the anterior segment. They've got them for the upper and lower anterior. They've got them in different styles. And it's just a handy way to make little tooth forms so that you're not having to bust your rear end and do it, from scratch. So just a great way to cheat. So I told you I'll give you some ways to cheat. Now, if you want to find a great deal on a waxer, give me a call. And can you see this right here, Tim? See this 0 number I'm holding up? That's how much money I make off of this, 0. The reason I promote these waxers, I've got 4 different waxers in my office, and this is my favorite waxer, and it's dirt cheap. They have got a 2-pin waxer. It's the same waxer you see here, only it's got 2 pins, and it's like $220. So if you order it through Fling seminars, that's the price you get. The reason I promote it is, 1, it's what I use. Number 2 is they provide those for me when I'm doing my waxing course, so I like it. But there's some rules about waxing. One of them is this: get the plaster out of the way. So if you're adding these tooth shapes onto plaster and the plaster's in the way, the wax is easy to carve away. You hit the plaster and it just creates a headache for you. I would rather over reduce the plaster and get it completely out of the way so it doesn't interfere with the wax. The other thing you'll see here in just a second is I have some white rope wax handy. I'll put just a dot of it, just enough to hold the tooth in place before I wax it to the model. So it kind of serves basically as sticky wax, although it's white, so it matches my other wax. I would tell you that I set my waxer to around 200 degrees Fahrenheit. 200, 205, somewhere in there is a good number to be working at. So that's the waxer I use. So if you have this type of waxer right here, which I've got that one too, it's just not nearly as efficient as the Whip Mix waxer that I just shared with you. If you turn that Whip Mix waxer up to its highest temperature, hold the Whip Mix white presentation stick wax against the shank right here, it will drip into these molds as fast as you could pour it. So you can fill these molds up very quickly, put them under cold water and cool it, pop them out, and you create a set of teeth very, very quickly. So if I've got a scenario where a patient comes in and say they've broken a tooth and we're going to have to make a temporary crown, we've already got these teeth shapes made. I will cut the plaster down to where it's out of the way. There you see a little bit of rope wax that was put in place just to hold the tooth. You'll place the tooth on there, and then it's a simple matter of waxing the axial contour, and literally in just a few minutes you wax a tooth. So it's something that you can do very, very quickly. And you can use the same principle on anterior teeth also. So when I say get plaster out of the way, here's what I mean. When I'm waxing all of this, notice I've gotten the teeth completely out of the way. There you see my rope wax, and then I've just added the teeth. So it goes pretty quickly like that. So keeping that in mind, let's take a look at just a few other concepts in regards to developing these sequence of treatment. In the mouth, how I treat things is a little differently than what I do in the lab. And so I want to give you just a few ways that I cheat in the treatment room so that perceptively I can make these things better and just do it very efficiently. And I will tell you that a lot of this I just developed from my experiences in the dental lab. So this is a patient that presented that her granddaughter was about to get married, and it was important to her to get her central incisors lengthened a little bit. So that's fine. Obviously, she's going to get some grafting up here, and she's got other issues that have to be dealt with. But I'm just trying to get her fixed up a little bit for her wedding. Back in the day when we did feldspathic porcelain, we would make a metal coping that would go onto a die, and to help us build the feldspathic porcelain onto the metal coping, we would make an index, much like you see on the back of the teeth right here. And that index is what we would use to put the porcelain on to help us establish the shape and the length of the tooth. So I just said to myself, why don't we do that clinically when we're doing composites? So here you see I've done a quick wax up. I make a silicone index. Now that I have the index, I go in with a really sharp scalpel, and I've created slits in here. And you can see that I put mylar strips in here. The index goes in place. Notice the mylar strips now, right, in those three areas. So now my interproximals, I don't have to worry about bonding the teeth together. So now I can go ahead and place my composite into the index to help me with my shape. And then you can use whatever techniques you like to do that, build that up, polish it, and very quickly you get some composite restorations. So that's just one way that we can help do things a little more quickly. Another thing that I think you really need to have in your bag of tricks is the understanding that in her case, reality is I cannot make this look great. She's got 8 to 10 millimeter bony defect there. She actually was a flight attendant that was in my practice. She moved to California. While she was out there, she lost a tooth. They did an extraction and they put a bridge in. She moved back to Oklahoma City. She said, Mike, I don't like my bridge. What can we do? I said, well, let's see. So I referred her to the oral surgeon, and they did a multitude of bone grafts. They got magic dust out. We did dances around fires. We sang songs around. We did everything you could do to try and improve her odds. So we got her provisionalized, and you'll notice that we've had 2 fixtures, one here and one here. And as we developed the soft tissue, we were able to get to a point that we actually created some papilla. And remember, this bony defect was up to here. So I was really pleased with that outcome. Now, here's the trick to making these crowns look great. Remember what I said, there's a reality of what you see here, and there's a perception of what you see. It's very critical that when you get the photos of these crowns that you get a spit bubble right there, because I want that spit bubble to block the dark hole that you see, because that's the only way I could really get that to look perfect. Because here's the deal. About a year later, she looks like this, and about 2 years later, she looks like this. And she comes to me and she says, Dr. Fling, I'm not digging it. What can we do? And so I referred her to Dr. Hess, and it's out of my hands. I'm kidding, Tim. You know, the grace is that with the 2 implant retained crowns here, they were screw retained. So it gave me the opportunity to do some things that otherwise I might not be able to do. And here's what I chose to do at this particular point in time. As I mentioned, they were screw retained. Those have come off. And as what you see here, this is actually a pink composite material. And as what I have done is, you'll notice right here, can you see the mylar strip right there? I put my mylar strip in. I actually, after etching and silaning and all the things you do to accept the composite onto the porcelain here, I use a sable brush. You can mix these colors. They have them in a multitude of colors, from light pink to dark purple. They have them in flowable, they have them in packable. So you can mix these to get the colors just right. And then I use a sable brush with my sculpting liquid, and I will go in with my sable brush and paint that in place and create the texture and match this color as well as I can. And so here you see I've done the central, here's my mylar. I've done my lateral, there you can see my mylar was right there. So floss, we can get in here, we can go up under that and clean around it. These are not under a load, so they hold up really, really well. And so this is what we ended up with. So this particular material that I used is from a company called Anexdent. There you see their phone number. Again, I've got zero financial interest in this company. I pay for this stuff just like you do. That's the kit that I have. It's really, really cool stuff. Now, I'm going to show you at the end of the day, there's maybe a better way to do it today. Definitely a different way. And we'll glance at that at the end of this presentation. But regardless, having this pink composite on hand can be a lifesaver, because the reality is there are times it can't be perfect and we have to change the perception of what is there. So keep that in your quiver of arrows that you might have. So as we get the anterior segment completed, I'll give you a few other techniques that I might use. This I just recently had published, this whole concept that I'm going to share with you for just a few minutes. And Tim, I think in your master track, when we come back later in the year, next year, we're actually going to do some of this. This is a lady that presented to me, and she had a lot going on. She had dental alveolar extrusion, she had vertical maxillary excess, and she had a hypermobile lip. We diagnosed all of that. We made our recommendations, and she said, Mike, you can do 2 out of the 3, but I'm not doing surgery. So we understood we could treat the hypermobile lip Botox. Is what we elected to do is orthodontically was to over-intrude her. And we did that in an effort to raise pregingival margin heights. So here you see my orthodontist, Dr. Birdwell, has done that. We purposefully slightly over-intruded her. She got to a point that with this intrusion, she called and she said, Mike, I feel like an idiot. Is there something you can do to make my front teeth look better? So I had Dr. Birdwell remove the wire, and she came by that afternoon. I took an alginate of these, and then while she was gone that afternoon, I waxed this up to how I wanted it to be. I then made a silicone index of this. And in my silicone index, I got flowable composite. I made a very thin layer of flowable composite down the facial. I cured that. My flowable composite, I then went up the lingual and I cured that. So this is, it's very deceiving. This is not a solid piece of composite. It is a shell. It is hollow in the middle. Okay? Now, what happened is she comes back the next day. I slightly beveled along here. I etched, I primed, I bonded. I placed packable composite on the inside of that shell. I seat it in place to where I want it to be. I remove the excess. I cure it. I went back with flowable composite on the margins to fill in any discrepancies. This appointment to do these 4 teeth in that composite took 1 hour. Now, if I were doing that by hand, it would just take me forever. So this is a technique that will just speed the process up so much. But you've got to be patient. You've got to get this shell overlay trimmed to where it passively goes into the position that you want it to go into. You place your packable composite on the inside of it. You seat it to place, remove any excess, cure that, and then go back with the flowable to repair any margins or discrepancies you might have. Now, here's the problem that I had with this case. She's got her composites here. She ended up getting debonded, and she looked at her teeth and she said, Dr. Fling, do we need to do veneers? And I'm like, I don't really think so. So that's what we stayed with. We didn't have any more treatment to do. So it's just a really fun technique. This is a case, the first case that one of my residents did using this technique. And I put this in here because I want to show you that it's just not that difficult. He's done a wax up. He makes a silicone index. And in the index, you see that he's made a very thin composite shell. The hardest part of this is getting the shell out without breaking it. Often to get this shell out, it's a two-person job. One of us will be stretching the shell facial to lingual while the other one's trying to tease it out. If you tease it out and it breaks, don't panic, put it back in the shell, add a little more composite, cure it, and just keep playing with it until you finally get it out of place. Here you see the shell that he got out of place. Now, here's what you have to do. You have to get a diamond burr and a high-speed handpiece, trim the underside of this until this passively goes to the place that you want it to go to. If you put it in place and it doesn't seat to where you want it to go, then it won't go to where you want it to go. I would rather be over-trimmed than under-trimmed. So you've got to use your eyes. Once you get it trimmed to where it passively goes into place, here you see he's not lined up right. He's got to move this over this direction, and he still may need to trim down to where this can seat down just a little bit more. But once he gets this placed where he wants it to go, in this scenario, these teeth are going to be individual. They're not going to be splinted together. So as a unit, we first get that to passively seat where we want it to go. And then once that's completed, we go back with a really thin disc right here on the lingual. We don't go all the way through. We just go about, maybe 5/6 of the way through. And then we get our fingers and you go snap and you break them apart. And you do that through every one. Okay? Now, on the patient napkin, or what, not the patient napkin, on a napkin behind the patient on the countertop, draw circles and write tooth numbers in there. And put these teeth in the appropriate tooth number. Because when you try to bond number 27 onto number 22, it doesn't look that great. So I like to keep up with it that way. So here you see him putting them on tooth by tooth now. He was using a mylar strip to help with the interproximal contact. He would get it seated to where he wants it to go, cleans the excess, cures it, flowable to fix the margin. And this was his first attempt to do it. And he got all of these on this patient in about an hour and a half. So it's a pretty efficient way to help. I would tell you that if I'm doing a larger case where they're going to be in provisionals for an extended period of time, I would use this technique with a material called Luxacrown. Luxacrown is used as an intermediate material over in Europe. Here in the US, it's used more as a provisional material. I want to share with you how this technique, though, can save our patients so much. This is a lady that presented in my office. She came to me through the internet. And, you'll have patients come to you through the internet and they want to come because, you got a 5-star rating and everybody says nice things about you. But sometimes, as you know, you get these patients coming in financially, they just can't afford much. And that was her scenario. And so if she were at the dental school, our treatment for this tooth would have been a root canal, a post and core, and a crown. And she just can't afford that. But I just didn't want her to lose the tooth. Well, what I did is I thought out of the box. I used my Nay Rapid Waxer and I made a composite shell out of flowable composite. I cured that shell. I trimmed it back, and notice what I've done here. It will passively seat to place, okay? After that's done, I've removed all of the decay. I put one pin in to help me with retention on the lingual. I etched, I primed, I bonded, I put packable composite on the inside of it. I seat it to place. I cure it. I go back with flowable where there's any marginal discrepancies. And now this is her core filling. But think about it. This might be a better treatment than anything else I could do for her permanently. Because if I'm going to do a full coverage crown, I'm going to be losing the facial part of that tooth. And structurally, it's the only good part of the tooth that she has left. The ferrule effect that I would have there is very, very minimal. So what a great service to do. What a way to save money for her. And it's just a technique that really helps us. Now, in terms of perception and reality, I want to share with you, this is a lady that presented to me, and she obviously has a lot going on. And we're dealing with all the things you would typically deal with. We've looked at airway, we've looked at joints, we've looked at occlusion. And at the end of the day is what's happening for her now is she's going to the periodontist to get these lower anteriors treated, and she's going to be going through ortho. But I've got to get her stable before she goes to ortho. So I'm going to use the same technique even in the anterior part of the mouth. Here you see I've made a composite shell for my lateral incisor and even for that broken central incisor. I trim it until they passively fit. I etch, I prime, I bond. I did the same technique on the back of her mouth. Here you see a molar that was just not in great shape. Before, I would have put a composite core in place, prepped it, put a provisional crown on it, and then while she's going through ortho, hoped I don't have enough marginal leakage that we don't have recurrent decay, or maybe the provisional crown comes loose. But with this scenario, this composite shell that I've made from my Nay Rapid Waxer is going to serve as my temporary crown. In other words, it's my core filling. So here you see I've made that core filling. That's what she's going to wear while she goes through ortho. I've done the same thing on the anterior teeth, and here you see her now readied, and now she's off to the periodontist, off to the orthodontist. Then we'll transition that to permanent restorations at a later point in time. So just some great techniques that I think you can use every day clinically to help you. What about a scenario like this? You know the deal. This happened to be a kid that at school, he was horsing around with a buddy, and he had a trash can get him in the face, and he lost the edge of his front tooth. For me to build this tooth up in composite freehand is just a royal pain. And I really don't want to crown that tooth. He's too young. Hang on, we just lost it. Let me get back to it here. You don't want to see my race car right now, do you? Let's see here. Where did he go? No. Tim, bear with me.
No problem.
Somehow it jumped to another lecture.
We're just pleased that you could join us today.
No worries. Okay, so here he is. And I did the same technique. I wax the tooth up. I make a silicone index. From my silicone index, I make a composite shell. I trim that to where it will passively go into place. I fill it with my packable composite. I fill the margins in with any discrepancies, and literally in less than an hour, you've got a restoration that's not bad. So utilize that technique to help. I think is what I'd like to do is share with you this one case, and then we're going to kind of go to a drawing exercise in this anterior segment as we can look at some of that. This is a gentleman that presented to me with a lot going on. He had a 6-unit upper anterior bridge, and he wanted a new bridge. And his only abutments were the 2 canines. They were endodontically treated. They had decay. They had no ferrule effect. It just wasn't going to happen. So I did all the things we've just discussed. I did a diagnostic wax up on him. In this case, I diagnosed him with dental alveolar extrusion here of the lower anterior, so I knew we were going to be doing orthodontic intrusion. We were going to use changes in vertical dimension to help us. But in this scenario, he could not afford to do all of that. He just couldn't do full mouth reconstruction. It just wasn't in his pocketbook. So I said, well, why don't I do in the mouth just what I did clinically? So I made my composite shells. And as what I did is, here you see I've added one of the composite shells on his lower right premolar. I then went over to the lower left premolar and did it. And then I would move back to this premolar and then to this premolar. And when I got back to these crowns, I put little retentive holes in there to help hold them. And I just continued to do that using those same shells. And notice I've made a lower occlusal plane that matches what we did in the diagnostic wax up. I knew in my diagnostic wax up that I could interdigitate, and so I did the same on the upper posterior. I got that occlusion, I got that equilibrated reasonably well. And then with that change in vertical dimension, he continued with the orthodontist with his lower anterior intrusion, and we got a provisional restoration on his upper anterior. Now, after he was finished with ortho, we had our intrusion that was done to this point. I did my wax up. This, once again, is my composite shell. That is not a solid piece of composite. It's a thin composite shell. Here you see me placing my packable composite into it. I'm seating it to where it passively goes to place. I will trim the excess. I'll use my flowable on the margins. I polish it up. So from here to here, all of that is composite filling. And that's what he's been with now for about 3.5 years, and it's held up really, really well. His provisionals all in the back, those composite fillings, believe it or not, all of those have held up too. Since that time, he has had 4 implants put in place, and we now have an implant retained bridge on the upper anterior. He is still wearing these composites in the back. Now I can treat him on a tooth-by-tooth basis. It doesn't force me to have to do the entire mouth at one time. So this was him in his provisional restoration on the upper anterior. This is him provisionalized upper and lower anterior. I want you to look at what this did for his self-confidence. Look how much better he looks. Isn't that great? So, well, it may not be quite the truth, but, you know, it works. Okay, so let's get back to some of the fundamentals of this anterior segment. I've shared with you how we can change the perception of some of these things with some of the clinical techniques that we've looked at. Understand that as we learn how to shape these anterior teeth, there's basically 3 kind of transitions of teeth that I would consider. Do I want the teeth to be youthful? Do I want them to be more adult-like? Or do I want them to be more elderly? And so as I talk with my lab, I would tell you that I sometimes prefer to have teeth that are more like this on the bottom than what I might have on the top. When we look at dentures, when we look at many teeth that technicians build, in the good old US of A, we tend to do things that are incredibly symmetrical. Sometimes to give it a little oompa, to break it up a little bit and to give it a little something more like this can actually be more aesthetic. So you've got to develop your own style. You've got to develop what you think looks right, because everybody has their own perception of what they think is aesthetic. So is what I'd like you to do, I want you to look at this word for just a second. And I want you to get a feel for how that looks. And now I want you to notice that I'm going to give you the exact same word, but doesn't it feel very differently? See, that's a perception based upon what you've seen in terms of how you feel. And that holds true when we're dealing with teeth. I think there's a number of things we have to communicate to our technician about, or that I need to understand as I'm shaping, as I'm contouring. Number 1 is texture. As we age, teeth get smoother. So if I want to give somebody a younger look, I'm going to give them a heavier texture. As we age, we might lose luster in teeth, and then of course occlusal staining. So I might talk with my lab and say, Jeff, make crowns T1, L2, O3. So it's just a great way to communicate what we might want those parameters to be. We're going to start by looking at a case. This is a guy that came to me, and he was in his 70s at the time. I did this case over 15 years ago. And so back when I did this case, I would tell you that global diagnosis was not even on my radar. And I will also tell you that there's some things about this case I might have done differently. But notice a few things. We're missing a tooth right here. If I'm going to put a lateral incisor in here, I really don't have enough room to do it. Over here, where this canine is in the lateral space, if that's going to be a lateral, it's going to be too large and it's going to look goofy. So this is the perfect case for us to learn that there's a perception of what you see, and that can be very different than the reality of what you see. So let's go through and take a look at this in depth. So remember what I said, there's a perception and there's a reality. Now, in Oklahoma, people, we think this is funny, okay? So, you know, I'm a little sick, but regardless, that's me. So remember what I said, there's the perception. It feels one way, but it can feel very differently based on what you might see. Here's the good news. The upper anterior segment, we can look at it from a very analytical perspective. So here's what I want you to do. I'm going to stall for a couple of minutes. Is what I'd like you to do. I want you to find a piece of paper. And your piece of paper, I want it to be, you know, notebook size, a pretty good size of paper, letterhead size. I want you to turn it sideways. And while it's sideways, I want you to draw for me the upper anterior teeth, tooth number 6 through 11. And I want you to draw them large enough that it can make sense. Because if you give me a tooth that's 3 millimeters tall, you're not going to learn anything from that. I want you to draw it to where the central incisor is maybe, oh, I don't know, 1.5 inches tall or so, 2 inches tall. And then the other teeth in accordance to that. So is what I'd like you to do is take just a few minutes, and I want you to draw for me tooth number 6 through 11. Okay? If you would like, I can sing to you while you're drawing. It won't be any good, but I could.
Is that going to be country or Western? Which one?
Well, in Oklahoma, it'd probably be a little of both. When I tell people my cowboy boots actually step in horse shit, they, you know, then they understand, right?
Yeah.
As a matter of fact, my wife is at the barn as we speak. But people, we do have running water. Tim can attest to the fact that we do have indoor toilets. We got all that stuff here. It's pretty nice.
You forget, you just about froze me to death. When I was there, your water heater was broken.
That's true. We had that fixed right after you left. So guys, here's what I'm going to challenge you to do. If you can get to a point that you can draw these upper anterior teeth in your sleep, I will promise you, your waxing will get better because you're going to wax like you draw. And I will promise you, your provisionals, your contours of your final restorations, everything about it's going to get better. It just will. I promise. It's so interesting. I'm an artist too. I do some artwork. And it's not very good, but I do it. And is what I can tell you is that if I have in my mind's eye what I'm going to paint before I paint it, I can do it. If I don't have that concept solidified in my mind's eye, it just doesn't work out that well. You have to get a burning image in your brain as to what it's supposed to be like. And if you can do that, to draw these teeth is actually a very learned event. And is what I mean by that is it doesn't mean you have to be an artist to do it. The reason a lot of people can't do it is because they simply don't understand what is it supposed to be. Does that make sense? Okay. So here's what we're going to do. If y'all have taken a few minutes to do that, I want you to find another piece of paper and we're going to draw them again. But as you draw them again, I want you to follow step by step what I'm going to give you here and see if this doesn't make sense just a little bit. Now here's the deal. The upper anterior teeth are on an arch form. They're not flat. And that's why perceptively what you see is very different than the reality of what is there. We have to learn to view these teeth on an arch form from a perceptive view. And that'll make a big difference for you. So find that other piece of paper. And it's what I want you to do is I want you to draw for me the two central incisors. And when you draw them, I want you to consider this. There is a frame to the central incisor. And one of the keys to it is right here. There's a height of contour, we call it a zenith, right there. And the zenith or height of contour on both the central and the lateral incisor should be slightly offset to the distal. Poquito. Is what happens is if you get this symmetrical to where it's not offset to the distal, you get something, I call it a butter bean. It's so symmetrical, it just looks fake. So create a height of contour. Here's your frame form, and you're slightly offset to the distal. Here's a test question. What's the ratio of length to width? And remember, it's 3 to 4. So on average, if the length of this tooth should be about, 10.5 millimeters or so, your width is going to be around 7.5 millimeters. That's a reasonable ratio to look at. Okay? So when you do your two centrals, have a height of contour slightly offset to the distal, have your ratio about 3 to 4, and then recognize that this incisal angle here is sharper. You're more rounded on the distal. And here we are looking at a ratio of 3 to 4. Okay? Now then, this is one of the most critical components that is going to help you understand the perception of anterior teeth. And it's called contour ridges. The contour ridge is the transition between the interproximal and the facial part of the tooth. When I see wax-ups, when I see contours of provisional or permanent crowns, one of the biggest errors I see is people rounding these over too much. If you round this contour ridge over too much, is what happens is you open up this embrasure area here, and it starts this connector area here, and it just starts to look incredibly fake. So these contour ridges, the best way to view them is when we're looking down the down the incisal edge of the tooth. So here's what you've got. I have a distal contour ridge, a mesial contour ridge, and a central contour ridge. Between these ridges, there is a depression. The depression is broader at the incisal, and it's narrower as we go gingivally. It is deeper incisally, and it gets more shallow as we go gingivally. And here's the part that is terribly, terribly difficult to explain in a lecture. I can show you in the lab easily, but in lecture, this is hard to explain. This depression here is incredibly subtle, and it is incredibly irregular. Okay, did you hear those two words? It's incredibly irregular, it's incredibly subtle. It's not two grooves. I see that all the time, and man, that just looks like bleh. It's very, very subtle, it's very irregular. Remember what I said? The best way to view it is looking down the incisal. So when you look at these two teeth, we've got a contour ridge here and here, here and here. This tooth obviously, perceptively, appears to be narrower than this tooth, but it's not. It's exactly the same width. The only difference is the contour ridges have been rolled in more. So I can use a contour ridge position to change the perception of what I see. So here on my centrals, notice the dominance of my contour ridge here. Notice the central contour ridge. Look at my depression and how heavy it is here and how irregular it is here. That's what gives the teeth that little bit of personality. That's what gives them that little bit of oompa. Okay? Take a look at these two central incisors. It's the only ones that I want you to look at. Look at the centrals. Get a feel for how that looks. Now, look at this one. Notice that those teeth appear to be narrower, don't they? But they're not. They're exactly the same width. And notice now, they look even narrower, don't they? And the only difference between the top two centrals and the bottom two centrals is the position of the contour ridges have been moved in. So I can use contour ridges to really affect the personality of the tooth. So we want to get used to looking down the incisal of these teeth. You can use a finger roll, and as the finger rolls down the tooth, you can see the negative spacing, and it really helps you understand that facial contour. But all too often, we look down the incisals and we see where those have been rounded and gone, and it just makes the teeth look so unnatural. Now, when you draw the lateral incisor, there's a couple of things I want you to keep in mind with the lateral. First of all, in terms of framing, it's very similar. You have a height of contour, you have a zenith that's offset to the distal. But remember what I said, the gingival here should be down just a little. The incisal will be up just a touch. And remember I talked about the ratio of length to width of a tooth? Well, there's the same ratio of width of the central to the width of the lateral. And that is also about a 4:3 ratio. Now, I've heard forever the concept of the golden rule. And it's what that is. It's a ratio that, for whatever reason, in our mind's eye, when we look at C, that tends to be a dimension of length to width. It's about 1 to 1.6 that just feels kind of right. And so the concept was that you could get this ratio and you could take it and you could turn it. And so here's our central. Now our lateral would be here and our canine would be there. So it's a ratio that just feels about right. You see it in nature. When you look at the rows of a Christmas tree, the bottom rows of the Christmas tree are in golden proportion to the row above that, to the row above that. In nature, if you were to look at my hand, this digit is in golden proportion to this digit, which is in golden proportion to there. So it's just something that perceptibly feels about right. And you see it in architecture. This was a picture of me actually just a few short years ago when I had hair, Look quite different now, don't I? You ever seen a guy that when he's wearing the tie, his tie comes up to like here, and you think, golly, that guy looks like a geek, right? It's just something that doesn't feel right. It's a proportion that doesn't feel right. Well, the reality is that anterior teeth, we don't see what we really see because there's the actual flat view, but remember, that's not what we see. We see a perceived view because we're on an arch form. The reality is that anterior teeth really aren't in golden proportion to one another. We can use that as a guide, but don't take it so literal. A good rule of thumb is the lateral incisor should be about 75% the width of the central incisor. That's a reasonably good rule of thumb to follow, okay? So as we look at the lateral, a few things. First of all, I would tell you that one of the things I talk with my patients about a lot is having an asymmetrical symmetry. Here's what I mean by that. I want my teeth on one side to the other to be cousins. I don't want them to be twins. Because when you get things just looking exactly the same, you just typically don't see that in nature. And one of the teeth that is the most asymmetrical of just about anything in the mouth is the lateral incisor, the maxillary lateral incisor, especially the incisal edge. It tends to be highly irregular, and very seldom when you see a left lateral incisal edge that is the same as the left side. So we've got to understand that we might use golden proportion as a guideline, but I like the 75% rule better. So when I do my framing on my lateral, remember what I said, we're going to have a zenith or height of contour that's slightly offset to the distal, just like with our lateral. Our free gingival margin is going to be up just a little bit. The incisal is going to be up just a little bit. We tend to be more rounded on the distal of the lateral than we are of the central. And that can hold true for the mesial incisal edge also. Remember, we're on an arch form, okay? So keep that in mind. Now then, a couple of things. We have our contour ridge here, mesial, distal. Remember, there's a central contour ridge. Because this tooth is on an arch form, it's rotated slightly. That rotation means the depression we see on the lateral might be more dominant than the depression we see on the distal due to the rotation in the arch form. Remember what I said here, the incisal edges on lateral incisors are highly irregular. Now, I know the deal. Too often patients want them the same length of the centrals and they just want them flat. And I tell you, you just don't see it in nature. Now, here's one of the big deals that can really help you with contouring a lateral incisor. On the gingival, there is a mesial S shape. See this right here? Right there. As you draw your lateral, if you draw it and it fills this out in here, and then it comes up, is what happens is it gets too symmetrical and you get that artificial look very quickly. So this is a little subtle nuance in the contour right here. It's a really subtle nuance, but it's a mesial S shape. Okay? Proximal contacts, as we go more distal, they get more narrow. And the reason that happens is because incisal embrasures open more as we go distal. So we have a smaller incisal embrasure here, it gets larger here, and then when we go back to the canine, it gets even bigger. Okay? Now then, look at our canines, because this is hands down the most difficult tooth to understand. And if I were with you in person, is what we would do is we would talk about all four of these canines. Now, there's not a right or wrong here, because I would tell you, I've outlined natural teeth here to get to this. So this is nature, but notice they're all different. The reason I want you to look at this is I want you to start to see in your mind's eye what is different about them all. Notice on this canine here, the height of contour is about in the middle of the tooth. Look at this one where it's down lower. It's more in the gingival third, then it rolls back more lingually. Notice that our incisal embrasure on the canine here is ovate. Our canine embrasure here is more convex. I'm not telling you there's a right or wrong. It's what I'm saying is I want you to start to look at these things because that's what you're going to use to help you understand how do I want it to be shaped. Now notice as I've done these canines, these are on a perceived view. They're on the arch form view. This is the amount of the canine that you should see. So let's talk about this just a second. With the canine, you have a mesial contour ridge, a central contour ridge, and this depression right in here is the most dramatic depression of anywhere in the anterior segment. It's broader on the incisal, it gets more narrow gingivally, it's deeper on the incisal, it gets more shallow gingivally, it is highly irregular, and it is subtle, but this is where it is the most dramatic. Okay? A rule of thumb with emergence profile, this area right in here, is to follow the contour of the buccal plate of bone. If your buccal plate of bone is like this, have your emergence profile like this, and then it should either come down or roll back lingually. Too often we see long axis of canines that come this way instead of down straight or lingually. Okay? Here's the deal about a canine. This is what will really make your canine stand out correctly. Not only is there a gingival S shape that you see right here. See it right here? It's obviously longer than the lateral S shape, but we also have one on the incisal right here. Is what we see often with canines is this incisal area right in here gets blocked out. It's contoured to where it comes over and it blocks this incisal embrasure. I will guarantee you if I'm doing a waxing course with you or if I'm shaping provisionals with you, I will almost guarantee you I'm going to open that incisal embrasure between that lateral and canine more than what you have. Okay? So let's look at this just a second. When we do the canine, here's the deal. This was a case that was incredibly difficult. I got to her after somebody had already put implants in. We had huge bony defects and we had to mimic some things to try and make it look better. I get it. There's nothing perfect about that, but we had what we had. The restorations, as you look at these, I want you to notice there is a mesial contour ridge, there is a distal contour ridge, and there's a central contour ridge. Notice the distance from the mesial to the central contour ridge is not as broad as the distance from the central contour ridge to the distal contour ridge. That's important to understand that because here's why. When you're viewing the canine from a perceived view, you should see very little to none of the tooth distal to the central contour ridge. That is the biggest error that you'll see with the canine incisor. Look at the canine here. Here's the central contour ridge. Here it is right here. You see a little of the tooth distal to it, but not much. Over here, you see almost none of it. That's the trick. All too often, we see this to where this is contoured out too far, and it just doesn't look bueno. Okay? By the way, start to look at these restorations. Notice I have not rounded over the contour ridges dramatically. I've kept them pretty, look how definitive that is. There's my mesial depression. There's my central contour ridge. You can see it over here on the central. There's my distal contour ridge, my mesial contour ridge, my central contour ridge. There's my depression. There's my depression. Okay? So, the canines, I already mentioned long axis. The long axis of these anterior teeth should point to our belly button. All too often we see canines that come straight down or even flare out facially. So get used to a long axis that goes down the long axis. So here's kind of a summary. Incisal edges along here. Pharyngeal margins here. This is going to drape the lower lip. The incisal will be slightly up, and we understand that the incisal edges of the lateral incisors are highly irregular. The incisal embrasures are going to open more as we go distal. The canines, we're going to have a S shape here and on the incisal here, and that's what helps keeps that incisal embrasure more open. Connector areas get more narrow as we go back distal, which makes sense because our incisal embrasures open up more as we go more distal. So let's apply that to our guy here. I have got too much space here for a lateral incisor. I want to make this look like a lateral. So what am I going to do with my contour ridges to make that perceptibly appear more narrow? And the answer is I'm going to roll the contour ridges in, because we already know that if I move contour ridges in, I will make this tooth look narrower than what it really is. I'm also going to cheat. I'm going to move midlines over. We know through all the studies that midlines aren't nearly as important as orthodontists want us to think they are. Now, the cant matters for sure, but we can move things back and forth like this. And we know the Kokich study said, what, 4 millimeters. Now, here's the problem with the Kokich study. That was done without lips. That was a study that was done on models. I don't know how practical that is clinically. Kokich Jr. did the same study, and he showed that maybe 2.5 millimeters is a better amount that you could get away with moving a midline. But the cant is everything. That needs to be perpendicular to the incisal plane. So here he is before. I did my diagnostic wax up and I moved the midline over. By moving the midline over, I close the amount of space on this side. I'm going to move contour ridges in on this side, and I'm going to move contour ridges out on this side. And so that is going to change the perception of what we might see. I've used a prep guide to help me understand. I'm going to over reduce here. I'm going to under reduce here. I went ahead and leveled the lower anterior plane, got the 2 old crowns off, got those temporized. Here he is in his provisionals. Now, this is one thing today I would do completely different. Back 15, 17 years ago when I did this case, I would tell you that I would have been scared to death to ovate anything out onto the tissue here. Today, I wouldn't think twice about it. But back then, I was nervous about doing it, and I didn't do it. But here he is provisionalized. Now, as you start to look at him in his final restorations, look at the contour ridges. Remember, this was our canine. Look how rounded that contour ridge is here. Yet on the other side, look how broad those contour ridges are there. And I've moved the midline over to close space and to open it up on this side. So it's understanding contour ridges and how that helps the personality of the teeth that allows me to change the perception of what is really there. And that's why I challenge you to learn to draw these teeth, because if you can do that well, I promise your provisionals are going to get better. I promise your wax-ups are going to get better. It just will. So I've actually done this with my lab tech. I've done it with all of my staff. We have all gone forward and played with this and get to a point that they can do it really well and you can do it really well. And I promise your dentistry is going to get better. I want to share 2 other things with you in regards to perception, and then we can have questions and answers. That sound about right, Tim? Okay. This is a lady. She actually is my neighbor. I can see her land from my bedroom windows right here. And I did full mouth reconstruction on her a few years ago. It was a comprehensive case. She's in her 80s. There's a lot going on here in terms of severe wear. She had some joint issues. I would have really liked to have done ortho on her, but given all of her health circumstances, et cetera, we ended up not doing that. I did change vertical dimension. We prepped, we got her provisionalized, we did all the things that you would do. So that was her. So here she is in her final restorations. Now, notice a few things about her final crowns. Look at this lateral incisor right here. When I talk about the difference between perception and reality, does anybody remember on her pre-ops what that was really like at all? Let's go back and look at that because it'll surprise you. This was her lower anterior right here. See that? Free gingival margin up. One of her complaints was she didn't like how that looked. Now, without question, the way to treat that would be to do some interproximal reduction and to orthodontically move that tooth facial, and that free gingival margin is going to take care of itself. But this is a lady that's older. She's gone through cancer treatment and chemo, and she's just like, Mike, I'm just not doing that. So I wanted to change the perception of what was there. So the question that you're probably asking is, all right, Mike, how'd you do that? What is that? Well, I just got to thinking out of the box one day, and I thought to myself, you know what? If I have an implant that's not positioned where I like it facially, or maybe the implant's too small, or whatever it might be, how come it's okay for me to create an ovate ponic form over the tissue for an implant, but for some reason I can't do it for a tooth? So I thought, what the heck? She's my neighbor. I see her all the time. If I end up killing her, I'll be the first one to know it. So what I did is I just made an ovate ponic out of porcelain that goes over the soft tissue, just like I was ovating something where I might have had an implant where I was having to make up her emergence profile there. Now, I did her, I don't know, it's been 4 years ago or so, I forget, something like that I treated her. I still have that temporarily cemented because I want to be able to pull it off and look at it to see if I actually was killing her or not. And I'm telling you, she can get floss right up under there and clean it. Tissues look great. I've done this several times since then on many other patients. So I think it's a great technique. Now, one of the things you need to have to play like this is you need a porcelain oven, because you might find you get it back from your lab and it doesn't adapt to the tissue as well as you would like. And so that brings me to one last thing that I want to share with you in regards to changing the perception of what you see. And when I was in Seattle just recently, Tim and I, we did a course with his residents and some other doctors there on using Mio. Mio is a chair-side stain that is amazing stuff. You can use it on lithium disilicate. You can use it on zirconia. You can use it on feldspathic. And it's technically not a stain. It's a colored porcelain, basically. Here you see zirconia. Here you see it stained. Let me go back. This is it stained, and it has not been in the oven yet. Now it has been fired. The point is that whatever you see on the crown in the mouth is exactly what you're going to see after it's fired, which is very different than conventional stains. Okay? The other neat thing about this stuff is that there's stuff where you can change texture. It's called Mio structure. And so if I've got an interproximal contact that's too light, I can easily add an interproximal contact. If I've got an ovate ponic form where I want to thicken the porcelain there to rest against the tissue a little bit more, I can easily add it to do that. So it's just a great material to have around to help change the perception of what is there. There is also Mio Pink. Here you see Mio Pink has been added onto zirconia here, where we've used it to add texture and to change color. So it's just a really neat material to keep around your office so that you can play with things to really customize and to really make things look cool. The beauty of this stuff is I can get something that is monolithic and I can make it perceptibly look like it's layered when it's not. And so I'm just going to challenge you to get this stuff. If you're up in Dr. Hess's neck of the woods, I know he'd be happy to work with you with this stuff. It's just great stuff to have around the office. So this is it. It's called MIO. Again, Tim and I both have got that much financial interest in this. We use it because we like it. It's just great stuff to have. It's easy to work with. You just have to put it in a ceramic thing like this to keep it. You do need a porcelain oven. If you want a great porcelain oven at a pretty dang good price, touch base with me. I can get you one. Once again, I get zero kickbacks on that. Whitmix helps us sell those. They provide porcelain ovens for the courses when I do a hands-on course with this stuff. So that's the reason I promote them, because I've got that oven in my office. I like it. I paid for my oven. And so that's the deal. So that's what I wanted to share with you in terms of some of these techniques we can use to help perceptively change the reality of what is there. So I hope this has been helpful for you. I hope you get a little bit of my weird humor. And I hope this is a way that'll help you change your reality of what's there based upon the perception of what is there. So Tim, I'm happy to open it up to questions now.
Thank you very much. We're going to take about 15, 20 minutes for questions here. We've got over 40 questions. So I'm just going to, the people have been upvoting on them. So if you have a question you like in that list of Q&A, upvote it so we get it to it. All right, question 1. Do you use a wedge for anterior composites? If not, how do you create a tight contact?
The answer is yes. I use whatever I need. So there's so many different techniques. I will use plumber's tape. I sometimes will use just a Mylar. I will sometimes use some of the metal matrix systems, but often, yes, I will use a matrix.
Okay, next question. How did you bond composite onto the porcelain in the implant example?
So, you know, you use a different acid to etch on porcelain. You'll use a hydrofluoric acid. And there's several people that have systems to do that. So it's simply a matter of etching the porcelain, silaning it, then applying bond, curing that, and then applying your composite to that. The beauty of it is that it's not in any load. So functionally, it holds up just fine because it's not chewing on anything. So there are several systems to bond to composite. Your orthodontist has them. They have them to bond brackets on the porcelain. So there's several manufacturers that have that. The only difference is you're etching the porcelain with a different acid.
Okay, billing question. How do you bill for your time in making these shells, especially in a PPO practice?
The answer is I have no idea, and I wish I could help you with that. I'm not on any insurance plans. But let me tell you this. One of the beauties of this shell technique is that it reduces my chair time a lot. Let me just give you an example. Let's go back here. Are we still sharing my screen, Tim?
Yes, sir, you are.
Okay, let's find this guy right here. I can tell you that to do that tooth as a composite filling, my fee's going to be around $485. Now, the beauty of it is if he came in today, I'm going to take an alginate, wax that up, make that shell. We pour it up in bite stone. It takes 8 minutes for that bite stone to set up. I've either got preformed wax things or I can wax it pretty quickly because I do a lot of waxing. I bet in 30 minutes, I can have that waxed and a shell made. Then to go clinically and to add that composite and put that in the mouth clinically, that's an appointment that's going to take me probably an hour. And that's about it. Now, I'm not customizing things in this, right? I'm helping him out in an emergency situation. Now, we don't have time today, but there are techniques where I will actually customize my shells, where I'm taking them out, going back and cutting back my shell and layering in different colors, layering in stains, then bonding that onto the tooth and just really trying to knock it out of the ballpark as a permanent laminate composite material. So there are ways you can, make it fancier. But the point is, this technique saves me time. I would do this quicker than if I were building that up by hand. Let me tell you that I've got to address something in regards to that question, and it's this. Culturally, it's how I do it in my practice. And whenever you're trying to change a culture of how you do something, it's a really difficult thing to do. And this happens pretty quick for me because I do it all the time. The first time you do it, you're probably going to cuss me. And it's probably going to take you a little bit longer because you just haven't done it that way. And what I'm saying is just practice with it, play with it. If you'll do it, it will go quicker. This patient right here, I'm telling you, I can do that full composite core on her faster than you could do any composite core in a temporary crown, I promise. And I've been less invasive to the tooth, and long term, it's better for the tooth. So I guess what I'm saying is just practice it, play with it, and you may find that it can actually be done quicker. And so in regards to the PPO practice, I guess is what I would say is maybe you can get to a point you can be more efficient with it.
Okay, what are your thoughts on analog versus digital wax-ups?
One of the things I say is the wax spatula of the young technician today is a computer mouse. And without question, that's where it's going to. Now, having said that, I would tell you that a lot of technicians prefer to refine in wax because you can do some things with wax that, that last nth degree that you just can't do on the computer. Mm-hmm. But without question, there's absolutely nothing wrong with the digital wax up. And there's so many libraries of digital teeth you can go to now. That's the way it's going. But as what I would do, I would get a digital wax up. You get that model printed, and then I would refine that model in wax. Then you could scan that if you wanted to, and then have your stents made of that.
All right. Thank you. Do you know what code you used for the composite edition?
Tim, I have no idea.
I knew you were going to say that. That would be my thing. Yeah, I don't know either.
I will tell you, it would be like on this case that we looked at. Here that I just showed you earlier.
Yeah.
That would be a composite core because I'm basically doing the entire tooth minus the facial. On that anterior case that I did here, I can tell you whatever code it is, I just don't keep up with them, is those back molars that we did. Those were composite core fillings. Here, this whole tooth is composite. And and I didn't have to do a temporary crown. So much more cost efficient because that is their temporary crown while they go through ortho. The anteriors, something like this here, I would file that as probably a distal facial lingual composite.
Okay.
And I'm sorry, I'm just ignorant about that.
No, yeah.
I just don't. I don't play with it much with insurance.
So on the vertical dimension, opening the vertical dimension on that case,
right?
How did you determine how much you wanted to open the patient, and how did you achieve that after making the shell? The doctor here is just kind of a little confused on that.
Well, first of all, this was a very difficult case, and the reason we had to do that is our first plan of attack was was for him to go through comprehensive orthodontics and to open vertical that way. and then to do full mouth reconstruction, possibly opening him even more. And so when I consider changes in vertical dimension, there are four things that I look at in considering changes of vertical dimension. The first is from a facial perspective. Is there a reason to change him in terms of pure facial aesthetics? And so in his case, here he is, the answer is yes. He looked like he was overclosed. So purely from a facial perspective, I would say let's open him vertically. And then there are three dental reasons that I would open somebody facially, or open somebody vertically. One is if I want to lengthen incisal edge position. I can open them vertically. That gives me space to increase incisal edge length. Secondly is I just need room. And thirdly is I want to decrease angle of disclusion. Now, this is a one-day seminar I do on severe wear, and it gets somewhat complicated, but the point is I would alter vertical dimension for one of those four factors or for all of those four factors. In his case, it was a little different. He just couldn't go through all of that treatment. We had to find a way to treat him on a tooth-by-tooth basis. So that's when I went to these composite overlays. And I had opened him vertically on his wax up just to aesthetically and from an angle of disclusion perspective, get him to where I thought we might want him. And I got to tell you, one of the terms I use for a diagnostic wax up is I would encourage you to call it a diagnostic guess up, because that's what it is. And that's what I was doing. I guessed where I wanted him on his diagnostic wax up here, based purely on aesthetics and based upon the amount of space that I needed. The only difference here is we were going to orthodontically intrude to gain the room that I needed. So the answer is it's an educated guess based upon those factors. The reason I elected to go to the composites over his posterior teeth like this in the back was because I'd done it on the model. And I knew that I'd opened him a couple of millimeters. So I just did that kind of blindly off the back, knowing that I could get him equilibrated the way I did on the diagnostic study models. Then we got the lower anteriors intruded, and then I built these up to get to this. And then here he is basically provisionalized now. So now I could go back tooth by tooth and restore these with permanent restorations if we ever wanted to. Now, the fact is, we've not done that. He's still in these. He's been in these for like 3.5, 4 years now. The only thing we've done on him permanently is he is wearing a permanent implant retained bridge on the upper anterior. But it's allowed me to go back and treat him tooth by tooth. But initially, it's a guess based upon those things that I just mentioned.
Okay, there's lots of questions about the composite shell technique and that, and I just don't think we're going to be able to get to them because we only have a couple of minutes left here. What journal was that article published in that you recently did with the shell?
It was just published like a month ago in, I think it was Dentistry Today.
Yeah, I think that's correct. I'll look
I'll tell you what I'd be willing to do. Why don't we do another webinar and we'll just do it on the composite shell overlay?
That's fantastic. We'll set a date for that here after the webinar today. And I think we'll end with the best question of any webinar so far from Dr. Wang. It is, have you been to the GW Zoo?
No.
You know what?
I tell you. He's happening, isn't he?
Yeah, yeah.
Goodness gracious.
But you did a heck of a job on his teeth.
And his hair, right?
Yeah, yeah. All right, Dr. Fling, we are just quite simply out of time here today. So thank you very much. I appreciate you volunteering to do another webinar with us. That's fantastic. Everyone out there, once we get the information for that, that'll go up on our website at washingtonagd.org, or follow us on Facebook. As soon as the events come up, they actually go up faster on Facebook, and that's Washington Academy General Dentistry. So Thank you very much. And with that, I think we're going to have to end our webinar now, and we'll talk to you soon, Dr. Fling.
Okay, thank you.
For the rest of you, we'll see you at noon for Deborah Engelhart Nash. Having trouble speaking. So grab yourself something to eat. We'll be back in 20 minutes. Thank you.
Thank you, Dr. Fling.
You're welcome.
Thank you, Dr. Fling.
Anything for you, Valerie. See y'all later. Y'all be safe.
All right,
Okay,
now
thank
let's
you
turn
too.
and burn.
All right.
Bye-bye.